Ons praat verder oor die beoogde Nasionale Gesondheidsversekering. Ek verwelkom nou die uitvoerende hoof van die Suid-Afrikaanse Private Praktisynsforum, Dr Simon Strachan, 'n gesondheidsekonoom van Wits Universiteit, Prof Alex van Heever en 'n bekende lid van Solidariteit-doktersnetwerk, Dr Angelique Coetzee. Simon, so there's a lot of concern from doctors and nurses saying that they leave South Africa if the NHI comes into effect. And I spoke to Dr. Nicholas Crisp, who heads up the NHI in the Department of Health, about those concerns. I'd quickly listen to what he has to say.
Every country that implements a national health insurance, the doctors threaten the same thing. Since 1948, when the NHS was created in the UK, and Bevan said, the Secretary of Health, Bevan, said, on Friday, the NHS starts, and the doctors all threatened to leave the UK. They didn't leave the UK, and it wasn't in their interest to leave the UK, and they then started to build a system. There's only one country left that does not have some form of national health insurance. That's the United States. And you don't just walk into the United States. You go to Canada. It's a pure single-payer NHI. You go to Australia. You go to New Zealand. All of these countries who are first world countries, Scandinavian countries, the UK, France, Spain, even if you want to go to less first world countries, Turkey, Colombia, Brazil, they're all NHIs of some form. They all tell you what you're going to get paid, how you're going to do it, where you're going to do it, and they set the prices. So it's not so easy to up stakes and leave.
Simon, what's your reaction to that?
So good evening. Yes, so we do know from surveys that have been done that there are a very high percentage of doctors who will seriously consider leaving because of NHI. Now, regardless of whether that becomes a reality or not, the truth is that the NHI is just yet another thing that is driving people to consider leaving South Africa. And it's not just healthcare professionals. The other point is whether they leave or not, the level of trust and faith that doctors are having to conjure up to try and believe in the system or not believe in the system. You're expecting doctors to accept a system in which they are literally being sidelined, literally being told where they can and can't work, having to agree to something where they have no idea how they're going to get paid. It's a bit like running a shop where somebody comes in and buys all the goods out your shop, and when they leave, you can't charge them. You have to now send the bill to one central place to get paid. So I think doctors have every right to be lifting their heads up and going, at the very least, what people must be hearing is, we are very, very worried about this.
Alex, another big concern is the possibility for corruption when the fund comes into effect. Dr. Crisp also says it shouldn't be painted by the same brush. The NHI shouldn't be compared to Transnet or Eskom. I think he envisions it being run like SARS. Is there something in the bill that sort of protects it against large-scale corruption?
No, nothing. And when you refer to SARS as your benchmark, SARS was captured. So the ability to capture our state organizations, and a state structure is one where the executive of government has an enormous influence over the appointments, the procurement, etc. And that's one of the reasons why they systematically fail in South Africa. It's not that one or two have failed, it's that they've all failed. And here they're actually proposing a state structure that is equivalent to every single state structure that has failed. So the alternative corporate governance designs can protect an institution from capture, but the other aspects of the governance framework are important for how a health system works. And I just want to clarify, Nicholas Crisp talks about NHIs being implemented in all those various countries. That's utter nonsense. All of those countries have vastly different health systems. All of them have evolved in their particular context. None of them are cut and paste health systems. So the proposals for South Africa propose to shut down two pre-existing health systems, our public and our private, and build them into a third, which hasn't existed before. They didn't do this in Spain. They didn't even do this in the UK. So that argument is just utter nonsense. And it's also important to note that South African doctors have alternatives, and they can leave, as well as our nurses. And I think we do have to be concerned as to whether or not we're driving our key personnel in South Africa, engineers and doctors and nurses, to other countries.
Angelique, as jy 'n jong dokter was en hierdie wet is deur die parlement, wat sou jou gevoel gewees het?
Hardloop, gaan soek vir jou 'n ander land. Dit is wat my gevoel is. In die eerste plek, soos wat ons tans sien, is baie van die jong dokters wat deur hulle gemeenskapsdiensjare kom, is glad nie eers toegerus om in privaat sektor in te gaan en te gaan werk nie. Hulle word geleer van meer van hospitaalmedisyne. Hulle is hospitaalsentries. So al die goed wat ons sien in die privaat praktyk, veral op primêre gesondheidsvlak, waarin jy moet besef dat jy moet holisties na jou pasiënt kyk, jy moet die medikasie ken, daar's nie 'n kliniek in jou spreekkamers wat vir diabetes hanteer en dan hoë bloeddruk nie. Jy moet al daai goed bymekaar bring. Die jong ouens wat klaar maak sukkel regtig om dit te doen. Hulle is nie baie goed opgelei nie. Hulle is boonbehalwe die feit, jy sal hoor, daar word gereeld gesê dat hierdie jong dokters kry nie poste in die staat nie. So jy weet, in my tyd was dit, as jy klaar gestudeer het jy nie gekyk vir die staat vir werk nie, jy het in die privaat sektor ingegaan en ons het die term squat gebruik. Jy het gaan squat of jy het saam met 'n senior dokter gaan werk. Op hierdie stadium is dit amper finansiëel half onmoontlik vir die jong dokter om uit te gaan met sy kennis wat hy het, 'n praktyk te gaan opsit waar daar geen praktyk is nie. Die kostes is net hopeloos te duur. Weer eens, hulle is nie opgelei hoe om te kyk na die administratiewe komponente nie, hoe werk mediese fondse. Ek praat nie eers van hoe om wat ons noem om te bil en hulle rekeninge uit te stuur nie. Hierdie jong dokters sit in 'n moeras van probleme. So weet jy, ek gaan dan liewerste na 'n land toe wat 'n baie beter infrastruktuur het, wat alreeds bewys is, en ek gaan soek my heil daar, as wat ek hier gaan sit en probeer regkom.
Simon, I want to stay with the topic of doctors. The supporters of the NHI will say doctors are only out to make massive profits. They're sometimes in cahoots with the medical aid schemes. Is that sometimes fair criticism?
Anybody has a right to make a living. And we become doctors because we care for patients. So people who have that level of criticism clearly don't understand the mechanics, the economics of medicine. Within the private sector, there is a funding mechanism. It may not be ideal, that there may be better ways to do it. In the private sector, we work extremely hard. The funding mechanisms that are generally purported by the states don't take consideration for the fact that in the private sector, you have very high overheads to cover. The problem with trying to implement something like the NHI is that you are then having to work for an amount determined by somebody else that, as I've said, generally doesn't take into account the cost of running a practice. You are being curtailed by being able to buy resources from one source at a set price and to sell at a set price. And the only way these systems work is to work harder. So if you're going to drive the healthcare force to work harder, not because they want to make more money, but because there are going to be so many more patients accessing healthcare, you're not going to be able to have your own set hours. You're going to literally work like we worked when we were junior doctors. And that breeds, what does that breed? Tired doctors. Quality goes down. There is a spiral in this that we really need to avert.
Alex, I mean, many of our viewers, if not most, are on a private healthcare package. Does this bill make private healthcare illegal?
Effectively, they would want to, because Section 33 of the Act says that if it's covered by the National Health Insurance Fund, it can't be covered by a medical scheme. Now, obviously, that's something that's not going to survive a legal challenge. But the mere fact that it's there is indicative of a mindset. Because you don't do this anywhere in the world. Again, Nicholas talks about healthcare systems around the world. None of them prohibit private coverage. So in this instance, our private coverage forms part of our universal coverage model. And people point to high costs in the private sector. But every health economist in the world understands that a private system suffers from systemic market failures which you need to regulate out to deal with. If you have market failure resident in your private sector, it's because government has failed to do its job. That's what the Health Market Inquiry stated. The Health Market Inquiry investigated the private sector and said these problems are systemic. Here's the diagnosis, here are the solutions. Government's failure is the cause of private market failure. So the high costs are because government has stepped back and done nothing. Now, I want to make this clear. I know why they did that. They've done it because they wanted to undermine the private sector. They have held back on systemic reforms of the private sector in order to be able to point to high costs and to say, look, that's why we need national health insurance. But all they've done is destroyed coverage for many people and harmed people in a cynical move to create some kind of demonstration effect for an unworkable model of healthcare, which is never going to be implemented.
Angelique, ons weet dit is nie om die draai nie, daar's nog 'n lang pad om te gaan voor dit in werking tree. Maar organisasies so Solidariteit dreig met regsaksie. Waarop gaan daai regsaksie rus?
Wel, ek het nou nie die detail van die regsaksie nie, maar dit gaan berus op die feit dat jy het vryheid van sprake het, jy het reg om te gaan waarna toe jy wil. En jy kan nie net kom en sê jy gaan nou single payer system hê in hierdie stelsel nie. Nêrens in die wêreld is daar so 'n model nie. Maar Suid-Afrika gaan hom inbring. Dit bestaan nêrens nie. So ons gaan nou dit inbring, ons gaan nou kyk hoe werk dit. Ons weet almal dat dit 'n groot probleem gaan wees vorentoe. So dit is nie net solidariteit wat dreig met regsaksies nie. Van die groot mediese fondse ook, juis op hierdie artikel 33 waarvan Alex nou net gepraat het. En jy kan nie vir iemand sê jy mag nie vir 'n diens betaal nie, net ek mag vir daai diens betaal. Jy weet, waar is jou reg en jou vryheid om ook te kan 'n diens te gaan kry as ek nie van dokter X hou nie, of ek kan net na dokter X toe gaan, maar ek weet ek kan nie goed na my sekere siektes kyk nie en ek is bereid om uit my sak uit te betaal om 'n beter diens te kry, dan hoe kan jy vir my sê ek mag nie, net jy die staat het 'n reg om daai diens aan te koop. Waar op aarde kom jy vandaan?
Simon, is your organisation also going to approach the courts? Do you think there's any chance of further meaningful engagement with government to make them reconsider some of the aspects of the bill?
Well, there's certainly nothing being shown at the moment that there is any chance that there's going to be meaningful engagement. We've certainly engaged as much as we possibly can up to this point in time. One would love to think that you could turn people around and change ideas, but I really do think that, I think we are all very aware that this is going to end up in legal action, and none of us can say we won't participate. If we're going to want to survive in this, we're going to have to participate. And the saddest thing about all of this is that to implement the health reform that's needed in this country doesn't require an NHI.
That is the sad truth. Simon, Alex, Angelique, baie dankie.